conference. I'm going to go ahead and open us with a word of prayer because I need it during these challenging times. Dear Lord, I thank you for the many blessings that you've given each and every one of us. Thank you for the gift of healing. Thank you for the ability to gather in a free country. Lord, I thank you for bringing all these wonderful speakers up tonight. Give us truth, give us wisdom, and Lord, help all of us be able to spread this truth so we can save more lasting lives. In Jesus' name I pray, amen.
Amen.
So my name is Dr. Ilona Farr. I'm a family physician. I grew up in Bush, Alaska in a trailer and went through the WAMI program. I've been back practicing in Anchorage since 1989, although I worked in Kotzebue, Barrow, and Seward after I graduated from residency in 1986. I was able to go on 2 medical exchanges with Dr. Ted Mala and his group to Siberia, which was currently then the USSR, so it's very interesting. I also had an opportunity to work in a mission hospital in Thailand when I was in medical school and traveled to many different countries. So it's a blessing to be here tonight, and we're all here to try and find out information that will save lasting lives. And so this is the Early Treatment Summit for COVID, and we have some of the world experts up here tonight and today, and we're going to tonight again to talk about the disease process. So I'm going to go ahead and have them pull up the first slide. Okay, so the beginnings of COVID. First of all, we have between 416 600 pilots and crew that go to and from overseas, including Wuhan from Anchorage on a regular basis. So we knew that we were going to be hit pretty hard when this came. And I remember seeing some of the videos out of China before all this media shut down, where there were students that were talking about something that hit Wuhan actually in September. And so whether that was this or something else, I do not know. But it was very interesting to kind of track the progress of this virus and then watch the physicians from China who, one ICU doc got on the internet and he said, please help us find a solution to this problem. I just had 5 patients die today from it. And so I started following this very early on, came to the conclusion that hydroxychloroquine would be something that would help my patients. And I think I actually saw my first patient here in February, and was probably exposed at that point in time. I started experiencing some weird symptoms, fatigue, kind of decreased taste and smell. So I actually went on chloroquine for 4 days because I was kind of curious. I had been on it in the past when I was overseas in the mission hospital, but I was curious to see if it had any side effects. So I went on it 4 days, my symptoms disappeared. I had no side effects at all. And that's what kind of triggered this whole journey with early treatment of COVID. I got on the radio, I warned people that this was coming in February and to start preparing. I also got it on stage at Botanical Gardens where I was giving a presentation because in addition to medicine, farming, especially growing fruits and vegetables, although I'm much better at fruits than vegetables, so I warned people about this. And then in March, when I was at Family Practice Conference, I actually got up for about 10 minutes and talked about some of the treatments that we could do to help prevent this from kind of ravaging Alaska. And that included the hydroxychloroquine, zinc, and also vitamin D at that time. Next slide. So in March of 2020, the COVID testing site opened in the parking lot right next to my practice. I went from a totally full practice to 0 patients wanted to come in. So in 1 week, I had to totally change my practice from an office space because I do a lot of fascial distortion model manipulation, which is a way of getting patients free of pain and helping the musculoskeletal injuries without any type of medication. So I went from that type of practice to total telehealth in 1 week. I was getting 65 calls a day from patients that needed medication refills. Called both insurance companies. I said, are you guys going to pay for telephone calls? Because patients refused to come in. They told me no. So I was basically faced with going bankrupt very shortly, or figuring out innovation, and then started doing the telehealth. So anyway, that's what actually saved my practice last year. In April 6th, I started my first patient on a Z-Pak and hydroxychloroquine. He'd been sick for 5 weeks was a young, what I would consider healthy 25-year-old male, but he could not walk across the room. It was really actually scary to watch him. I was doing telehealth and he was just sitting there with labored breathing. So anyway, I started him on hydroxychloroquine Z-Pak, and he was dramatically better within 5 days and said, hey, you saved my life, continue to do this treatment on other patients. Went to Costco, and there was only seaweed left on the shelves there. So if you ever have to prepare for another pandemic, don't worry about stocking up on seaweed or fresh vegetables. The toilet paper and everything else was gone though. I started researching, did the Dr. Zelenko protocol, and that's what I kind of followed for a long time. And in May, I actually mentioned ivermectin as a possible treatment for COVID. But I also, in May of 2020, asked the governor when we were going to be opening up, because I thought we've got hydroxychloroquine, vitamin D, the Z-Pak, patients are responding to this. I was wondering why we weren't opening up. And instead of opening up, so we would have this kind of go through us in the summertime when people are naturally out, have high vitamin D levels, they lock things down even more. So when we ended up with our second surge, we ended up with people with low vitamin D levels who weren't able to get out, weren't able to social distance outdoors, and it actually made the problem, in my opinion, much worse here. In August of 2020, I'm a member of the American Association of Physicians and Surgeons, and I heard the presentation from Dr. McCullough and actually started following his protocol for treatment of my patients. And then in November of 2020, I got firsthand experience with COVID. I had one patient that came into the practice that was coughing. We pre-screened everybody else. And I heard him coughing, so I had an N95 mask, a face shield, gloves, gown. Only patient that I've ever done that to in my whole career. And within 3 days, I was still sick with COVID. So I was one of the fortunate or unfortunate ones that ended up going through the initial COVID and then also the cytokine storm. So there's kind of two parts to this disease, and Dr. McCullough does an excellent job of explaining it. The first phase is the viral phase, and that's what the hydroxychloroquine, ivermectin, and Z-Pak help with. But then there's the second phase with the cytokine storm, and I kind of imagined it like all these little proteins attaching to all my cells and my body literally attacking them. It felt like your lungs were being glued together, you were having trouble breathing, but you also had brain fog, and you could not think about what you needed to do. So fortunately, I was doing telehealth during that time. I had to because my patients all had COVID at the same time, and I knew if I didn't do telehealth, they would not get treatment. But I was very fortunate to have a whole bunch of physicians call me up when they heard I had COVID, and each one of them gave me a different piece of the puzzle so I could actually get out of that cytokine storm. Like Dr. Gittimer called me up and said, hey, do colchicine. Dr. Reed, one of the radiologists, called me up and said, hey, just had a patient 24 years old with an MI, and one of the radiologists plotted off their arm with this. Go on aspirin and stay on it a minimum of 3 months. This is bad stuff. Dr. Sue Haverling, I called her up. She goes, well, if you're having trouble breathing, why in the heck aren't you using a nebulizer? So anyway, it's difficult to understand, but I can totally understand now why patients have difficulty making decisions and actually seeking treatment because of this brain fog that people have when you have COVID. Part of it's because of the hypoxia, but part of it is because the deleterious effect that this virus actually has on your neurosystem. So anyway, I did telehealth from 5 to 7 hours a day to keep my practice going. And the way I did it was my nursing staff at the office would check the patient in, have the chart. I would do handwritten notes at home. And in order to sterilize them so my staff wouldn't get COVID, we put them in an oven at 160 degrees Fahrenheit for 30 minutes. And then my daughter would take them using pot holders over to the office and stick them in each individual chart. So that was my Alaskan innovation to making sure I got patients taken care of. Later on, I went ahead and started doing some of the FLCCC protocols with more of the vitamins and stuff like that. And there's many people in this community that called too late or are their friends and they have other physicians. And so I actually had a 74-year-old friend that was admitted to the hospital, and we instituted a 52-day Nehemiah prayer for him. He had leukemia, should not have come out of this, and on the 53rd day he called me and said, "Thank you for all your prayers." I could feel them. So there's also a spiritual component to this too, and I think that's really, really, really important for people to recognize. It's really important to connect with loved ones during this time, whether it be FaceTime, calling the hospital, or text, or whatever, because the people, because of the limitations in the hospital, in terms of getting in touch and actually touching loved ones, the texts and everything else are all really important. So just a few of my stats from July 1st, 2021 to current. I've seen over 108 COVID patients via telehealth, and it's actually more since I counted them up. 4 of those were hospitalized within 24 to 48 hours, and mostly because they had diarrhea and vomiting, and I don't have super good treatment outpatient for that. I've had 2 patients that could not get the ivermectin here in town. One of them was hospitalized. The second one, the family actually flew to Soldotna to get the ivermectin, flew back, she got 1 dose in, was taken to the hospital. They refused to give her the ivermectin, and that is their policy. I got an email on it last night at Providence not to give people ivermectin because it's against their policy, and they will not allow physicians to do it. So that was really tragic because she is the only one that I lost, and I know there's other people. Sometimes people are too late in the course of the disease and ivermectin is not going to work, but it's my feeling that it's a totally safe medication and people should have the right to try. This disease is with us forever. We're going to see different strains. It's really important that we know how to identify it and have early treatment to prevent all this death and disability that we're having. Over the last year and a half, I've treated over 700 patients with COVID. I've had less than 20 in the hospital, and again, only the 1 death from the lady that did not get her ivermectin. Relatives of those I've treated and other friends who I did not get a chance to treat have died because once they were admitted, they could not get ivermectin and other life-saving treatments. There's a lot of different things that we can use. Ivermectin is not the only medication, but they can't even get IV vitamin treatments or anything else that might help boost their immune system. So, next slide. So this is the protocol that I have used based on Zelenko and McCullough and research that I did. Is this a perfect protocol? No. You guys may have better ones. I'm looking at them. I'm not an expert. I'm just a family doc. But this is the treatment protocol that I have been using ever since last year. And I've had really good success with it. I have people wait 4 hours in between these medications to help decrease any possible GI side effects, and I also have them take all of these with foods. We're also going to have a handout a little bit later in the day with a list of supplements and stuff that a group of us kind of put together to try and help, and you can hand this out to your patients. It's got some websites on it, so if your providers here will not prescribe these medications, then hopefully you'll be able to get treatment. But we're hoping, there's only about 24 of us that I know of in the state that are actually doing these protocols, and there's only a few pharmacies, and so it's been very heartbreaking. I mean, absolutely heart-wrenching for my staff and I to have to turn people away, but we were working until 7 o'clock or later every night in August to try and do as much as we could to save. Then 2 of my staff came down with COVID, and it just became overwhelming, so I started having to call other practitioners. We got former practitioners that were willing to help us, but it's still overwhelming. There's so many people that need treatment up here, and we could easily be preventing a lot of the stuff that they're seeing at the hospital by this early treatment. So the supplements that I use are vitamin D3, 10,000, and these are when people got sick. And this is my protocol. Other people may have better ones, but vitamin D3, 10,000 international units a day, adult aspirin, 325 milligrams with food. And I put 3 to 6 months here because before COVID, whenever I brushed my teeth and I had taken an aspirin, my gums would bleed. It actually was more than 6 months, I think almost 7 months before I noticed my gums bleeding, even with an adult strength aspirin. So this disease takes a long time to eradicate, or the side effects of the disease in a lot of people, much longer than we're realizing. I actually was able to get my lungs a lot better. I actually used some vitamins called the Reds that a physician here told me about. Really helped me get my lung function much faster. And it's the original Reds vitamin. It's high-dose vitamin A. Probably long-term, I'm not sure if you want your patients on it. It's actually used for treatment of macular degeneration, but that is one thing. And I've actually told a couple of my patients that, and other friends that have been on oxygen when they got out of the hospital about it, and most of them have been able to get off of the oxygen within just a week or so, which is truly amazing when they were dropping down their oxygen down to 56% when they didn't have the O2 on them, and then they're up 70s, 80s, and now up to 90s within just 2 weeks. Vitamin C, 1,000 milligrams twice a day, and people can go up a lot higher on that, but some people cannot tolerate that very well. Zinc, again, twice a day with food, and that totally depends on tolerability. Some people can tolerate zinc very well and some can't. Quercetin, I did 250 milligrams twice a day, and then there's a lot of other different vitamins and supplements that I hope the speakers will be talking about later because I'm not as familiar with them. The cytokine storm protocol, if I have patients that I think are at increased risk for cytokine storm, I'll have them have a nebulizer, so I'm handed home with albuterol, ipratropium, and budesonide. Also, I've been using Singulair, people that go through that. Colchicine worked for me. I just ended up having to do 3 doses. And I did low-dose prednisone on me, although the protocols call for much higher dose now. Also, spironolactone is a new thing, and there's also some other things that I'll have them address later. Patients have been using CPAP at home. They've been using home oxygen concentrators that they've purchased off internet. And I've even had some innovative people that have gone and got their oxygen tanks from their airplanes here and used them to keep loved ones alive. My problem is I'm seeing some people that are going down to 69% O2 flat out refuse to go to the hospital because their feeling is remdesivir and the ventilators will kill them. And so they have been staying home, and I have been sweating, just praying that nothing happened to them. And so it's been a very challenging time as a family doc. Fortunately, all of them, amazingly enough, pulled through. And families now, their extended families are all patients now. And I've been successfully treated them. But unfortunately, I've had a couple of times when a spouse would come to me, I would treat them, but the husband did not get treated, ended up going into the hospital and dying. And they weren't patients of mine, so I had no way of actually being able to call up and ask the hospital that they would consider some of the other innovative treatments. I leave messages, but they were never returned. I use Zofran for nausea and ginger, and then patients have a lot of different ideas about different things, so I was kind of listening to them, and that's how I'm constantly coming up with new ideas on treatment. So this is one of the problems we're up against. Is the state pharmacist, and a lot of, unfortunately, pharmacists and other providers have kind of the same attitude about ivermectin, like it's a horse pill, and it's not. I mean, it's been used 4 billion times all over the world as a better side effect profile than aspirin, Tylenol, penicillin, sulfa, I mean, all the drugs that we use commonly. And it's very frustrating for me because it should be inexpensive. I was paying $140 for 20 pills to cover my staff, and other physicians' offices called me up, asked me to order for them, and so we got some of these meds out to them too. But, you know, they're saying that we're providing them this information, and it's absolutely the opposite, and it's extremely frustrating to me as a provider. They are not the ones that are treating these patients. They're not the ones that are actually seeing. All they're doing is dispensing medications. And I love pharmacists, don't get me wrong, but we're the ones that actually are treating these patients from birth to death as family physicians. So we get to see what works and what doesn't. And in my experience, it's ivermectin, hydroxychloroquine, Z-Pak, or if they're allergic to Z-Pak, doxycycline, or if they have a history of cardiac arrhythmias or QT prolongation, I do the doxy instead of the azithromycin. So COVID expenses in Alaska were one of the most expensive places in the United States to treat. I think we're the third on the list. $208. And CMS gives a 20% bonus if you treat with remdesivir, so there is definite financial motivation there. Whereas, you know, for under $300, I can treat them with ivermectin, hydroxychloroquine, and Z-Pak. And what we've done is the people that want treatment packs before they get ill, because they're high risk, they travel a lot, we're actually having to mail out of state a lot to get these medications, so it's a 48-hour delay. So I've been trying to just treat the acute patients here with ivermectin locally, and I've actually stuck with a little bit lower dose of ivermectin because I can get 2 people treated if I do the combination of ivermectin and hydroxychloroquine and Z-Pak with a little bit lower dose of ivermectin, and that way, again, I can treat 2 patients instead of just one with the higher dose on the FLCCC website. So I want to talk a little bit about vaccine mandates. So my problem with these is, first of all, I'm not anti-vaccine. I have a whole bunch of vaccines in my office that I give children and adults on a regular basis. I do not have the COVID vaccine in my office because some of the first people here in Alaska had anaphylactic reactions to it. I don't have the staff to be able to handle that, or the freezer capacity either. But I really feel that there's some people that should not get vaccines. They have a history of clotting disorders, cardiac disorders, a family history. They have a history of adverse reactions to previous vaccines where they get them and they're sick in bed for a month, can't breathe, on nebulizers and everything else. And yet, when I write these medical exemptions for these people, they are not being honored. And so I'm seeing a lot of vaccine side effects. However, I will say this, almost half of my practice has been vaccinated. It is by their choice. And I have reviewed with a lot of them when they call me up which vaccines I recommend and why I recommend it. I have been recommending, if they ask me which ones they have to get or want to get, I've personally been recommending the Pfizer because I'm seeing many less side effects from it. So basically, if you're over 65, I have been recommending the vaccine. I may change my mind after this conference, but we'll see what their data shows. So my biggest problem is people have natural immunity. I have natural immunity, and that is being totally ignored. You know, and so I really think we need to, and I think one of the problems is people that have had COVID get the vaccine. It's my feeling after much observation that those people are the ones that have a much more risk of adverse reactions to these vaccines. I want to know if there's a blood test that I can screen these patients. I was talking to Dr. Cole last night, and I said, why did I go through the cytokine storm? And he goes, well, you've got a genetic defect. And I thought, couldn't you have worded that a little bit nicer? It's like, okay, so I'm defective, now I know it. But apparently there's antibodies to interferon and maybe an IgA deficiency that I had. So the question is, can we pre-screen some of our high-risk patients to see if they're the ones that are going to be going through this cytokine storm that is killing people? And if so, get them on ivermectin or hydroxychloroquine for prevention of these diseases. And is there something that I can do, some blood test, that will tell me whether these are the people that are more likely to end up with strokes or cardiac problems? So there should be, let's see, which slide am I on? Next slide. Okay, I'm past that one. So I just talked about that one. Next one. So anyway, there should be an open discussion about vaccine effectiveness. Per Bloomberg News, Israel is preparing for possible 4th COVID dose. My question is, when does this end? And because of the original animal research where most of the animals died with repetitive vaccines, my question is, what are we doing to our population? And the problem is these boosters are behind. So the original vaccines were for the Alpha strain. We're already on the Delta. And again, there's multiple other strains that they're projecting out through 2023. And so I think we're way behind in terms of our vaccine effectiveness to the specific strain of virus that's going around right now. We don't know the long-term side effects of the vaccines and boosters. I personally am looking at the Novavax and Sanofi vaccines, and I'm interested in hearing more information about those because to me, they're more traditional vaccines and I'm hoping they're going to be safer. So in my own practice, I'm going to talk about the people that I've seen. So again, Over 90% of my patients that have had the vaccine have not had any side effects or problems with it. About 10% get sick for a week or so, but there's a few of my patients that have had very serious and significant consequences of getting the vaccine. I had a 26-year-old with a stroke, a 42-year-old with a heart attack, and I recommended against getting the second vaccine. His cardiologist said, oh, it'll be fine. Well, he ended up with 3 days of severe chest pain in the ER 3 times. So this vaccine obviously was having an adverse effect on his heart. I had a 50-year-old with uncontrolled muscle spasms starting 15 minutes after the vaccine, lasted 3 months, and it took me 3 months to get it controlled. And I did it with a combination of ivermectin, prednisone, and also Mirapax. Interestingly enough, I tried all kinds of different things, and interestingly enough, the Mirapax was what worked. I also had a 60-year-old with tachycardia. She was someone that did not want the vaccine because she had had an ablation, was totally stable, and she really was scared that the vaccine would actually cause adverse cardiac reaction in her. We gave her an exemption. Basically, they ignored it, told her she would lose her retirement and everything else if she did not get the vaccine. She elected to go ahead and get it. We put her on a regime to try and prevent vaccine injury that include aspirin, hydroxychloroquine, and ivermectin. And I'm not sure which combination she took, but after she got her second vaccine, she's had tachycardia up to 200, and she's now on 17 different medications. So these vaccines do have adverse reactions, and a lot of patients know who they are because of family history, or relatives that have had adverse reactions. And so I think we really need to be able to opt out of these vaccines if we feel like they're going to be harmful to us. Sweden and Denmark have stopped the Moderna COVID-19 vaccine for younger age groups over the risk of cardiovascular side effects per Reuters. And I have been doing some exemptions, especially for pilots, because of their risk of blood clots, and I personally don't want a pilot having a heart attack or myocardial injury, or my military folks having the invasive pericarditis. And I just talked to a cardiologist yesterday. She's already had 2 of these people, but just 1 cardiologist, and that, so you can multiply that times the 25 or 30 cardiologists that we have. So there's actually a fair amount of this pericarditis and myocarditis that we've been seeing here in Alaska. And then one of the flight surgeons was talking on a YouTube video, and she was saying in 2020, there were 20 servicemen of all the different military branches that died of COVID. And this year alone, after the vaccine, there's 88 reports of myocarditis or pericarditis or different cardiac problems associated with these vaccines. And she said they carry a 66% chance of mortality within 5 years. And she'd personally seen 3 young men with blood clots, pulmonary emboli, shortly after the vaccine, and one of them died. So we don't know a lot about these vaccines, and that's why I'm really frustrated that Air Guard moved the deadline of December 2nd up to October 28th, just before this conference. And so it's very difficult to get exemptions for some of these young men that have real concerns about these vaccines. So, next slide. So this is kind of the letter that I wrote. It's just one of many. It's not a legal letter, it's a medical letter, and there may be things that I should or should not have in there, but that's just an example of one of the letters that I have written to try and get some of my patients that I felt were high risk or should not get the vaccine until safer vaccines are available. So, next slide. So these are some of the problems to solve here in Alaska. Getting the COVID vaccine exemptions honored for people with natural immunity or medical contraindications. Getting ivermectin as outpatients quickly. Only 1 pharmacy has consistently filled the prescriptions for me here in Alaska, in our whole state. There's other pharmacies, when they have certain pharmacists on hand, that will fill the prescriptions, but it's kind of hit and miss. There's also been a problem with pharmacies running out of it, and again, 1 patient, again, flew to sold out and didn't get it. We can't get ivermectin to patients in the hospital up here now, or any other treatments. They're just using pretty much the remdesivir, oxygen, CPAP machines, and they are using some steroids, but the ventilator is one of the big things. The right to try is not for cancer alone, and we need to really encourage people to be able to use treatments. But, you know, if we were doing these outpatient treatments and I could get other physicians to actually save the lives of their patients instead of telling them to go home, take aspirin and call us if you're really sick, that is absolutely insane. There's monoclonal antibodies out there in addition to the oral medications, and you're going to hear from these physicians today about some other ideas for treatment for COVID. So again, I want to thank Mayor Bronson especially for the way that he set up the WICA program over at the Golden Lion. It's fantastic. You can just go online, type in the patient's name, email, address, set a time for them, so it's slick. And so I saw 2 patients with COVID yesterday, high risk, got on the computer, and they were over there getting the monoclonal antibody treatments within an hour. So I really want to say thank you to him for setting that up, because it really does help save our Alaskan lives. Okay, next slide. So other things that we need are good long hauler protocols and treatments, and I know they've got some on the FLCCC website. Dr. Luke has treated over 30 patients with what my patient called a stellate ganglion block. He says it's a little bit different. It has to do with the autonomic nervous system. But anyway, he's doing injections, and his paper is soon to be published. But my patient had return of taste and smell within 15 minutes. She said it was absolutely stunning. He says that it works some for cardiac arrhythmias and also menstrual abnormalities he's seen some improvement in. So it's going to be interesting to see what research shows up there. Remdesivir, is it causing renal and liver damage in the hospital? That's what I'm hearing from my patients. Vaccine side effects, again, we need a blood test to determine who's at risk for these side effects. And the NIH has already begun doing studies to find out why women are having all of these menstrual abnormalities. And I also worry about long-term fertility issues in these women. And we need to find out why these young men are getting this myocarditis, if it's based on blood type. Because one of the things that I always ask my patients when they call me up and have COVID, or try to remember to, is what their blood type is. Because in my experience, people with B positive and A positive blood type tend to do a lot worse than people with O or O negative blood type. So anyway, it's just kind of, and there was a study that kind of supported that. I don't know whether it's true or not, but that is what I'm seeing in my practice, and so I tend to be a lot more aggressive with those patients. So anyway, I just wanted to say hero awards for the physicians and stuff that got up in front of Congress and really tried to make people aware of what was going on. The Global COVID Alliance is putting this on, Dr. John and Miriam Nolte, because without them and their motivation and actually talking and inviting these folks up here, we wouldn't have this opportunity. And the many clinicians and pharmacies who are saving lives by doing these protocols. And the next speaker is going to be Dr. Malone. Two other things. One, ornaments designed by my nephew. If you want to make a donation for me, it'd be great.